You know, you see a newborn and their chin looks, well, noticeably small.
Mm,
It might seem like just one little thing, but sometimes that's the first clue to something more complex.
exactly. Like Pierre Robin syndrome.
Precisely. PRS. It's a fascinating example, really, of how things that look separate, like the jaw, the tongue, the palate, are actually all connected in development.
Absolutely. They're not just isolated issues. It's more like a chain reaction, a sequence of events happening early on.
So for this deep dive, that's our mission,
Right.
to really get into Pierre Robin syndrome, or PRS.
Yeah, we want to unpack it properly for anyone revising this. Understand what it is, what kicks it off, and importantly, how it's managed.
And we're basing this on a solid set of revision notes we've got here.
That's right.
Okay, let's jump in. Pierre Robin syndrome. What's the core definition we need to remember?
So, at its heart, it's a congenital condition, and it's defined by this triad of features.
A triad, okay.
First, micrognathia. That's just a small lower jaw. Second, glossoptosis. Bit of a mouthful, but it means the tongue is sort of displaced downwards or often backwards.
Okay, small jaw, tongue position.
And third, a cleft palate.
Yeah.
Now, here's a really key point, especially for revision.
Mm-hmm.
PRS isn't usually considered a distinct syndrome on its own. Think of it as a sequence.
A sequence, like a domino effect.
Exactly like that. It's a sequence of developmental anomalies, things going slightly off track during embryogenesis, really early development in the womb.
Right.
So any disruption then, when the jaw, tongue, and palate are forming, can set off this chain.
That makes sense. So
Right.
one thing leads to another. It's not just three random things happening.
Precisely. And thinking of it as a sequence really helps understand the pathophysiology and even the management. Addressing that initial micrognathia can affect the rest.
And you might hear different names for it.
Yeah, you might hear Pierre Robin sequence,
Yeah.
which really emphasizes that point,
Yeah.
or just PRS, sometimes PRM complex or Robin complex.
But they all mean the same thing.
They all point to the same cluster of features, yeah. Named after Pierre Robin, the French dental surgeon who first described it and how to manage it.
Okay, so small jaw, tongue displacement, and a specific kind of cleft palate, often without a cleft lip, right?
That's the typical picture, yes.
Let's focus on those features a bit more. The micrognathia.
Right, the small jaw. Or sometimes it's called retrognathia, meaning the jaw is set further back. This is often the kind of initiating factor.
First domino.
Kind of, yeah. Because the lower jaw is small or retracted, it just doesn't give enough space or forward support for the tongue as it develops.
Oh.
And that leads directly to the glossoptosis, the tongue being displaced down and back.
And that causes problems because...
Well, here's the crucial bit. That backward displacement means the tongue can actually fall back and physically block the upper airway.
Oh, wow. Leading to breathing difficulties.
Exactly. Airway obstruction. That's a major, major concern. And then you've got the cleft palate. In PRS, it's typically U-shaped, sometimes V-shaped.
And no cleft lip, usually.
Usually no cleft lip, correct? And this opening in the palate can make feeding harder and potentially worsen those breathing issues, too.
Airway obstruction in a baby. That sounds really serious. So what's the underlying cause? Why does this sequence actually happen?
Yeah, that's the big question, isn't it? And the honest answer is we don't know the exact cause in every case. It's complex.
But we have some ideas.
We do. We understand it's likely a mix, a combination of genetic factors and possibly environmental influences during that really critical early developmental window.
Okay, genetic and environmental. Let's look at the genetics first. What links are there?
Well, PRS can just happen sporadically, like out of the blue, no family history, just the sequence itself.
Okay.
But quite often, it's actually part of a wider genetic disorder or syndrome.
Such as?
Well, common ones linked to PRS are Stickler syndrome and also Treacher-Collins syndrome. Various chromosomal abnormalities have been implicated too.
So an underlying genetic issue can make this sequence more likely.
Definitely. Take Stickler syndrome, it involves a collagen defect. That affects not just the jaw and palate development leading to PRS,
Right.
but also connective tissues elsewhere, like the eyes causing severe myopia or retinal detachment, and the joints affecting epiphyseal development.
Ah, so seeing PRS might prompt looking for those other Stickler features.
Absolutely. That specific triad PRS plus the eye and joint issues is a big clue. Recognizing that association is vital for managing potential long-term problems in those other systems. It's a key point for differentials.
Makes sense. What about the environmental side then? You mentioned maternal factors.
Yes, some potential risk factors have been identified. Things like maternal smoking during pregnancy, significant alcohol consumption,
Okay.
and exposure to certain medications have been suggested as possible contributors.
But the how isn't clear.
Not fully defined, no. We know their potential risks, but the precise ways they might disrupt that early development, maybe affecting cell signaling or tissue growth, that's still being researched. It's likely a complex interaction.
Okay, so just to list those risk factors clearly for anyone revising. Maternal smoking, maternal alcohol use during pregnancy, and having one of those related genetic syndromes we mentioned.
Those are the main ones identified, yes.
Right. Now, let's dig into the pathophysiology. How does this sequence actually unfold step by step?
Okay. So it all comes down to that disruption in embryogenesis, affecting the lower jaw, tongue, and palate development.
And it starts with?
It often starts with the micrognathia, the small jaw. Because it's small, it doesn't create enough room anteriorly.
Right. Not enough space at the front.
Exactly. So the tongue doesn't move down and forward as it normally would. Instead, it gets pushed up and back. That leads directly to the glossoptosis.
The tongue displacement.
Yes. And this is the really critical step in the sequence. The displaced time falls backward into the pharynx,
Blocking the airway.
blocking the upper airway. That's the mechanism.
So the small jaw directly causes the tongue position issue, which directly causes the airway blockage. The sequence is really clear there.
Precisely. And that airway obstruction is what causes the respiratory problems, the breathing difficulties we see in newborns with PRS.
And the cleft palate adds to the problem.
It can, yes. It disrupts the normal structure of the mouth, making it harder for the baby to latch and create suction for feeding. And it can sometimes further compromise that already tricky airway space.
Okay, so we have this chain. Small jaw, displaced tongue, blocked airway, often with a cleft palate making things harder. Now, if a baby shows up with these features, what else could it be? What are the main differential diagnoses?
Good question. Differential diagnosis is crucial. You need to consider other conditions with overlapping features.
Like?
Well, Treacher-Collins syndrome, which we mentioned, Stickler syndrome, although often PRS is part of Stickler's rather than a differential, it's good to keep it in mind. Naegger syndrome is another. And sometimes you might just see an isolated cleft palate without the significant micrognathia or glossoptosis of PRS.
Okay, how do doctors tell them apart?
It often comes down to looking for additional features. For example, fetal alcohol syndrome might have some facial similarities, but the overall pattern and neurodevelopmental issues are usually different.
Right.
Or velocardiofacial syndrome, VCFS. That's linked to a 22q chromosome deletion. Kids with VCFS might have PRS, but they also often have heart defects, learning difficulties, maybe psychiatric issues later. Those extra things point towards VCFS.
So you're looking for the whole picture, not just the jaw, tongue, and palate.
Exactly. You need a really thorough clinical exam, looking for subtle clues, maybe eye or ear differences, limb abnormalities, things that might suggest one of the rarer associated syndromes.
Got it. So how common is PRS? What's the epidemiology like?
In the UK, the estimates vary a bit, but it's roughly around 1 in 8,500 births, up to maybe 1 in 14,000 live births.
Okay.
And just for another reference point, a German study found an incidence of about 12.4 per 100,000 live births.
So not incredibly common, but frequent enough that obstetricians, pediatricians, midwives, they need to recognize it.
Absolutely. You might not see it every week, but you will encounter it.
Okay. Let's talk about the clinical presentation then. What does it actually look like at birth? What are the signs?
Well, the most obvious things are the facial features. The micrognathia, that small, sometimes recessed chin.
Right.
And when you look in the mouth, you'll see the glossoptosis. The tongue seems positioned further back or lower than usual. And then the cleft palate, typically that U shape, no cleft lip.
And functionally, what problems does this cause immediately?
Big problems, often. Difficulty feeding is very common. Difficulty breathing is the major one, potentially leading to respiratory distress. You might see increased effort of breathing, maybe cyanosis, that bluish tinge from low oxygen.
Which sounds like an emergency.
It absolutely can be. Severe airway obstruction from the tongue falling back can be life-threatening right after birth. These babies often need immediate airway support.
Wow.
And because feeding is difficult, poor weight gain or failure to thrive is a common consequence if not managed quickly.
Can it be picked up before birth?
Sometimes, yeah. Antenatal ultrasound might show the small jaw, raising suspicion, but often it's diagnosed right at birth when you see the craniofacial features and the baby has breathing or feeding issues.
And what might be needed immediately for breathing?
In milder cases, just careful positioning might be enough initially. But for more severe micrognathia and obstruction, they might need a nasopharyngeal airway, a small tube through the nose to keep the airway open behind the tongue, or even intubation.
Okay, and longer-term breathing issues.
There's definitely a risk of obstructive sleep apnea, OSA, later on. And don't forget, that cleft palate itself causes feeding problems separate from the airway issue. So a really careful examination is key, looking for those facial features, but also checking for any other abnormalities, eye problems, ear problems that could signal an underlying syndrome.
Oh, thorough exam first. Then what investigations are done to confirm things and check for related issues?
Okay, so after the physical exam, focusing on the mouth, jaw, palate, imaging is often next.
Like x-rays.
X-rays or maybe CT scans. They help visualize the facial bones, assess how small the jaw really is, and get a better look at the airway anatomy.
Makes sense. And genetics.
Genetic testing is really important. Because PRS is so often linked to other syndromes, testing can help identify if there's an underlying genetic cause, like Stickler's or a chromosomal issue. That guides long-term management and counseling.
Are there other tests commonly done?
Yeah, definitely. You'll monitor their oxygen levels closely with pulse oximetry. Arterial or capillary blood gases might be needed to check ventilation if they're having significant breathing problems.
Okay.
Sometimes bone x-rays if you suspect a skeletal issue. And crucially, given those syndrome associations,
Eye and ear checks.
exactly, early ophthalmology and audiology assessments are really key. You want to pick up any associated vision or hearing problems as soon as possible. It's a comprehensive workup.
Right, covering all the bases. So once you have the diagnosis, how do you manage PRS? Especially in those critical early days.
Management has to be individualized, tailored to how severe it is for that specific baby, and it absolutely requires a multidisciplinary team MDT.
Lots of different specialists.
Yes, but the immediate priorities are always feeding and airway. Early intervention for feeding problems is critical to ensure they get enough nutrition and grow properly.
How do you manage the feeding challenges?
There are several strategies. Positioning is key. Feeding the baby more upright can help.
Okay.
Using specialized bottles and teats designed for babies with cleft palates can make a big difference. Things like the Haberman feeder, for example.
Right.
But if they really struggle to feed orally despite these measures, then tube feeding is awfully necessary, at least initially. Maybe a nasogastric tube or sometimes a gastrostomy tube for longer-term feeding support. A simple way to remember could be position, pacing, specialized products, potentially placement of a tube.
PPPP.
Yeah.
Okay. And the airway. You mentioned positioning.
Positioning, yes. Often placing the baby prone on their tummy can help the tongue fall forward and open the airway. That's often the first step.
But if that's not enough,
Then you might need an adjunct. A nasopharyngeal airway, that little tube we mentioned, can work well. Some babies might benefit from CPAP, continuous positive airway pressure.
like adults use for sleep apnea.
Similar principle, yes. Delivering pressured air to keep the airway splinted open. And in the most severe cases of obstruction, intubation and mechanical ventilation might be needed temporarily.
Okay. What about surgery to fix the underlying anatomy?
Surgery is definitely part of the longer-term plan. The cleft palate typically gets repaired surgically, usually somewhere between 6 and 12 months of age.
Okay.
And for the small jaw, the micrognathia, that's causing the airway obstruction. The main surgical option nowadays is mandibular distraction osteogenesis.
That sounds complex. Distraction.
It's quite clever, actually. Think distraction for the jaw. The surgeon makes a controlled break in the jawbone and then attaches a small device. Over several days or weeks, this device is gradually turned, slowly stretching the two pieces of bone apart.
And new bone grows in the gap.
Exactly. New bone forms in that gap, effectively lengthening the jaw. This pulls the tongue base forward, opening up the airway behind it. It can be really effective.
That's amazing. Is that the only surgical option for the airway?
It's generally preferred now. An older technique, sometimes still used, is tongue-lip adhesion. Think sticking the tongue forward,
Okay.
where the tongue is surgically tacked to the lower lip for a while, again, to hold it forward out of the airway. Less common now, distraction is available.
And you mentioned a procedure during birth. Exit.
Ah, yes, the exit procedure, ex utero intrapartum treatment. That's for very rare, severe cases diagnosed before birth where they anticipate immediate severe airway obstruction.
How does that work?
It's done during a C-section. They partially deliver the baby but keep them attached to the placenta so they're still getting oxygen from mom. This gives the surgeons time to secure the baby's airway, maybe intubate or perform a tracheostomy before the cord is clamped and the baby has to breathe on their own. Highly specialized.
Incredible. And what about hearing? You mentioned ear assessments.
Yes, very important. The cleft palate affects the function of the eustachian tube, which connects the middle ear to the back of the throat.
Leading to ear infections.
Or fluid buildup, glue ear. This can cause hearing loss, which, if not treated, can impact speech and language development. So early audiology checks are standard.
And might they need grommets?
Yes, tympanostomy tubes or grommets. They're often needed to help drain fluid from the middle ear and maintain normal hearing. Think ear tubes for speech. Getting hearing sorted is crucial for their overall development. And of course, speech therapy will likely be needed later on too because of the palate issues.
It really highlights that multidisciplinary team approach, doesn't it? Neonatologists, surgeons, feeding specialists, audiologists, speech therapists, geneticists.
Absolutely. Coordinated care is essential.
So with all this intervention, what's the long-term outlook? What's the prognosis for kids with PRS?
Generally, it's actually pretty good for most individuals, especially if they don't have a complex underlying syndrome.
That's encouraging.
Yeah. The prognosis definitely varies depending on how severe the initial problems were and whether there are those associated anomalies or syndromes. But with the right management, started early.
Right.
You see huge improvements in feeding, breathing, and eventually speech outcomes. So the long-term outlook is usually favorable. Think good long-term with early help.
Are there lingering challenges, though?
There can be, yes. Even with successful surgery, some kids might still have some degree of palatal dysfunction affecting speech, or maybe ongoing issues related to their jaw growth or dental development.
Okay.
And the airway needs monitoring, especially regarding sleep apnea risk. So regular follow-up with the team is really important as they grow.
But overall positive.
Overall, yes, especially regarding the most critical issues. It's often noted that by about age 3, many children have made huge strides. They're often managing a much better oral diet, and the airway obstruction tends to improve significantly as they grow. That's a nice milestone to keep in mind.
That's great to hear. Finally, what are the main complications that clinicians need to watch out for?
Okay, potential complications. Well, feeding difficulties leading to poor nutrition and failure to thrive is a big one early on.
Right.
Respiratory distress, obviously, from that airway obstruction risk. Speech and language delays are quite common due to the palate and sometimes hearing issues. Dental abnormalities can occur because of the jaw and palate structure. And of course, if there is an underlying genetic disorder or syndrome, that brings its own set of potential complications specific to that condition.
Is there a way to remember those?
Maybe think feed RSDG, feeding, respiratory, speech, dental, and genetic syndrome complications.
Feed RSDG. Got it. And the key is monitoring.
Absolutely. Regular monitoring allows for early detection if any of these complications start to arise. And early intervention for any problems, feeding support, airway management, speech therapy is really crucial for optimizing their long-term outcome and well-being.
Fantastic. This has been a really comprehensive look at Pierre Robin syndrome. We've gone from that initial, perhaps subtle sign of a small chin, all the way through to the complex developmental sequence, the triad of Micrognathia, Glossoptosis, Cleft palate, and the really vital multidisciplinary management needed.
Yeah, understanding it as a sequence is key, isn't it? And seeing how crucial that early diagnosis and team approach is for improving outcomes.
Definitely.
Yeah.
So a final thought for our listeners, maybe something to mull over.
Well, thinking about PRS as this sequence, this chain reaction in development, it does make you wonder, doesn't it? What other seemingly isolated congenital features out there might actually be the first sign of a broader underlying sequence or syndrome that we haven't fully pieced together yet?
That's a great point. It really underscores how interconnected development is.
It does.
Brilliant. Well, for everyone listening, especially if you're revising pediatrics or genetics, hopefully this deep dive has been really helpful. And if you're looking for more top-notch revision resources, definitely check out PassTheMSRA.com.
And there's also freemsra.com for some excellent free materials, too.
Great resources. Thanks so much for joining us through this deep dive.